So next speaker, Dr. Hiteshi Jain. Yeah, she will be speaking on an atypical case of atypical CSCR.
Yes.
Atypical case of atypical CSCR.
Good evening, everyone. I'm Dr. Hiteshi, and I will be talking about an atypical case of atypical CSCR. So we had a 50-year-old hypertensive and diabetic gentleman who complained of painless loss of vision for 3 weeks. He had a vague history of joint pain for which he was taking homeopathic medication, and he was a teacher by profession, and he claimed that he was under considerable professional stress. On examination, the vision in his right eye was hand movements. The anterior segment was normal. The IOP was normal. The EOMS were full and free. And the left eye visual acuity was 6 by 18, and the rest of the anterior segment examination was completely normal. On fundus examination, this was the picture we saw. In the right eye, there was exudative RD, which was mainly inferiorly involving the macula as well. And there were multiple subretinal yellowish lesions. In the inferonasal quadrant, there was also an area of vascular sheathing with two hemorrhages next to the sheathing. The left eye showed subretinal yellowish lesions mainly concentrated at the posterior pole, but there was no exudative RD as such. The OCT on day 1 of presentation showed a lot of massive subretinal hyperreflective material and neurosensory detachment. In the left eye, also there were some areas of RP alteration and subretinal hyperreflective material. An FFA was performed. So this is the FFA of the right eye, which shows early pinpoint hyperfluorescence, which increased as the FFA progressed, and the intensity and the size increased. In fact, if you see nasal to the disc, you can also see a kind of a smokestack appearance. The left eye also, although not as much as the right, showed pinpoint areas of hyperfluorescence increasing in intensity and size. So taking into consideration the history of the patient, that he was on homeopathic medication, he was under stress, and he was a hypertensive, looking at the clinical picture of extensive subretinal fibrin, diagnosis of atypical CSR was made. His routine lab for uveitis was also performed, and serum 8 AM cortisol was also done. Serum potassium was done, which was all within normal limits. He was asked to stop all homeopathic medications. Focal laser to the points of leakage was done, and tablet eprenone 50 milligrams once a day for 2 weeks was started. So you can see the follow-up of this patient. This is the second picture is at 2 weeks of starting eprenone and post laser. You can actually see the well-defined track of subretinal fibrin, which is tracking downwards. And at 4 weeks, that fibrin has almost become just a linear structure, and there is no RD at this point. So the above two images are of the right eye. You can see the subretinal material at the fovea, which resolves at 4 weeks with minimal fluid, and in the left eye, it has completely resolved. So these are my references, and I had 2 questions to the panel, like, if I may. What would you have done in this particular case, and in cases of atypical CSR or CSR in general, how long do we continue eprenone?
One thing, if you are suspecting the stress and the homeopathic medicine, usually it is seen, and we have seen some cases, if you stop the causative factor, there is no need of any other treatment in such cases.
Okay, even in such chronic looking
Yes,
CSR
but at least
cases.
you can wait,
Okay.
because we have seen few cases that if you stop the, like, patients on this hormonal therapies or steroids in any form, if you stop, they improve.
Okay. Ma'am, in this case, he had given a very vague history of taking homeopathic medication a month back, so there was nothing really to stop at that point. That's why we did this.
Usually, we give eplerenone around 3 months, but you will get serum potassium levels at 1 month and review the patient. So this is what give in chronic CSC patients usually.
BCVA, you didn't tell what happened to BCVA.
Yeah, Yeah, sorry, I did not mention that. So the BCV of the right eye became finger counting 1 meter. The left eye was maintained at 618. It didn't improve the VCV.
So now come back to the last. The only thing I would have done is I would not have started application actually.
Okay.
I would have stopped the causative factor and laser, because laser, I have a lot of pictures where this fibrin has melted and patient has dramatically improved from say FC or finger counting to 612, 69 also. But I am happy that your documentation is very good, but you keep it under follow-up. This patient will likely improve more also, should improve more, because the track center picture is much
Yes,
better
sir.
than the third picture in fact.
Mm.
And most of these patients do pretty well either with laser, because if you do both of them you don't know
Which one
what
is
is working where. So I would have actually, do you have any laser photographs? You see, you should show one FA where you show the laser marks,
Okay.
so that
I
will
don't have that
increase
right
our
now.
confidence.
Yeah.
Where have you must have lasered that smokestack laser
Yes,
database
definitely.
only,
Yes,
yeah.
we do.
So that should also be part of the presentation,
Okay, sir.
because you have just orally told that laser was done,
Mm.
but angiography will show that laser spots.
Yes.
But the second question was, what was the first question was?
Would you have managed this, approach this case differently?
Eplenon we normally give in a central involving CSR. Your patient was a non-central involving leakage, so laser alone should be fine.
Okay.
Could you explain the vasculitis which you were telling?
Yes, sir. That actually was also a question. It threw me off actually, because that vasculitis with hemorrhage did not really fit into the picture.
It could be a
But
secondary CSR, because somebody may have given because of vasculitis steroids and maybe then developing CSR. Yeah, because
One of the patients, we have a very similar patient, and that patient has been treated massively with steroids because of suspicion of leakage.
yeah.
And because it also has a multifocal type of presentation, bilateral presentation. Usually CSR won't be a bilateral. This kind of even multifocal usually doesn't.
So that's what I was saying, because if you see vasculitis, most of
See is the history of apart from stress, like using medication like steroids and any hormonal. If you better to do laser, even if prevents recurrence